So neuropathy, another MLA condition lecture. So neuropathy, all it means is nerve not functioning well, neuropathy. Your nerves can be sensory, so they can conduct sensation or feeling. They can be motor, so help you move, or they can be both, they can be mixed. And if you have damage to the nerves, you can get, by definition, sensory problems, motor problems, or a mixture of both. And this is a lower motor neuron problem, so you'd expect reduced reflexes and wasting. So neuropathy, we classically think of as a slowly progressing problem that begins from the most distal points of the feet and then later the hands. And we often think of it as sensory with wear and tear. We call that axonal. And that's diabetic neuropathy. But that's the form of neuropathy that we think of, although not all neuropathies present that way. So we can describe neuropathies in lots of different ways. So how quickly it comes on, so it can be an acute, a subacute, or a chronic, slowly progressive distribution. So it could be in one limb, or it could just be in the hands, or it could just be in the feet, or glove and stocking. Causation, so this person has a B12 neuropathy. They've got a neuropathy because of a lack of B12, diabetic neuropathy because of their diabetes, or pathology. We do that less commonly in terms of sampling. We don't sample nerves very much. But when we do nerve conduction studies, we can divide into axonal or demyelinating. Axonal is the most common, and that's damage to the nerve itself. That's generally irreversible, and we see it with toxic or metabolic problems like side effects of drugs, B12, diabetes. Demyelinating neuropathies are more likely to have a degree of reversibility, and that's the stripping of the myelin sheaths around the nerve, often inflammatory. And if you see this sort of thing in the context of an acute or subacute onset with dropped reflexes after an infection, for example, you might think of something like Guillain-Barré syndrome, and that can have a degree of reversibility. And I've just got a big slide for you there just to read about it, but essentially that talks about how axonal neuropathy is damage to the nerve itself. You get a reduced amplitude, so when you test the nerve and you get the trace neurophysiology, because the nerve itself is damaged, you get less output from the nerve. So reduced amplitude, damage to the nerve itself, generally irreversible, toxic metabolic causes, generally slow. And demyelinating neuropathy, because it's damage to the myelin sheath, which helps accelerate the conduction, you get slow conduction, but the amplitude is generally normal because the nerve itself tends to be intact, and that can be reversible if you address the inflammatory cause. So the classic neuropathy that everybody thinks about is diabetic neuropathy, which is chronic and toxic metabolic. Alcoholic neuropathy is probably the other common one. It's not really clear which one's the most common, and sometimes it coexists. It can be difficult to get a history of long-term alcohol use, particularly if it was in the past. You get symptoms of sort of burning, dysesthesia, sort of pins and needles in the feet, and they gradually ascend. You would expect kind of that sort of sensation to get to the knees before it affects the hands. If you think about the length of the nerves, yeah? You see my socks there? You don't reverse that if you stop drinking or if the diabetes is now better controlled, but you can slow later progression. So it's important to address anything reversible or treatable. Sometimes, though, in diabetes, there's been a recent sort of understanding that if you very, very rapidly correct diabetes, if you get someone who's been managing with a very high sugar for a long time and bring them down suddenly, you can get a paradoxical worsening of neuropathy, and that's treatment-induced neuropathy of diabetes, or TIND. And diabetic amyotrophy, which is sort of very severe pain and wasting, usually in one leg, but it can be two, is a form of that. So you do have to have some caution about really rapidly correcting diabetes. B12 deficiency, you can get lots of things with B12 deficiency. It can just make people feel tired. It can mimic forms of dementia in some cases, but generally it will cause a neuropathy. It can look quite similar to a diabetic neuropathy, but sometimes you can have spinal involvement where the dorsal columns, so joint position sense, proprioception is affected. You'd see it on a scan, so you get posterior signal change in the spinal cord, and people can have brisk knee reflexes, but absent knee jerks classically, and their joint position sense would be reduced. So, for example, they wouldn't detect the vibration of a tuning fork. So, correctable and an easy thing to treat. You might not completely resolve that, because there's often an axonal element, but certainly could stop it getting worse. And Guillain-Barré, we've mentioned that, so that's an example of an acute para-infective or after an infection neuropathy. So it can be all sensory, it can be all motor, but more commonly it's a mixture of the two, and you'd expect that to sort of rise up the body classically. Usually about 2 weeks after an infection, diarrhea and vomiting is the typical one with Campylobacter, and essentially the immune system clears the bug and then doesn't stand down, sees the myelin sheaths of your nerves and thinks that looks a bit like a bug. So it's a maladaptive response. The body is trying to protect you but maybe causing you some harm. It can be life-threatening if someone loses their respiratory drive, if they go into type 2 respiratory failure. That's when it involves the axial and diaphragmatic muscles, and then you need ITU support. So we do use things like IVIG and plasma exchange, but if somebody's imminently going to lose their drive to breathe, that is not going to help. That will improve things over days to weeks. They need critical care. And also IVIG and plasma exchange, they increase the rate of improvement, but not the overall prognosis. So, neuropathy. Nerve dysfunction, lots of different causes, and you can broadly divide them into axonal and demyelinating. Trajectory can be really helpful to allow you to diagnose, and also the other medical history. Do they have diabetes? Do they have recent diarrhea and vomiting? Is their diet bad, for B12 deficiency? Guillain-Barré, it's important to address whether or not somebody is critically unwell and have breathing compromise, and always look for treatable or correctable things. Because if you can't take the neuropathy away, you can at least stop it from getting worse quickly.